Good evening. My name is Kayla Magwa. This is Vital Signs on the Front Lines. For millions of Nigerians, getting sick is not just a health crisis, it's a financial catastrophe. A single hospital admission can wipe out years of savings. A cancer diagnosis, an emergency surgery, or even the birth of a child can plunge an entire family into debt. Every day, countless Nigerians delay treatment, resort to self-medication, or simply watch loved ones suffer because they cannot afford the cost of care. Despite being Africa's largest economy, Nigeria still relies heavily on out-of-pocket spending, leaving millions of people ill and people who are from poverty. In a country where access to healthcare can determine who lives and who dies, the promise of health insurance has never been more critical. The National Health Insurance Authority was created to change that reality. The NHIA Act of 2022 transformed what was once a largely formal sector insurance scheme into an institution charged with one of the most ambitious social responsibilities in the country, delivering universal health coverage. The goal is simple. No Nigerian should be denied health care because of a lack of money. And saddled with the responsibility to deliver this mandate is my guest tonight, the Director General of the National Health Insurance Authority, Dr. Kelechi Ohiri. He's a medical doctor who earned his Bachelor of Medicine, Bachelor of Surgery, MBBS from the University of Lagos. He furthered his education at the Harvard T.H. Chan School of Public Health, where he obtained both a Master of Public Health and a Master of Science in Health Policy and Management. He also completed a Healthcare Management Fellowship at Harvard University, strengthening his expertise in health systems leadership and policy. Beyond his formal academic qualifications, Dr. Ohiri is a Desmond Tutu Fellow of the African Leadership Institute and a member of the Aspen Global Leadership Network, reflecting his commitment to leadership development and public service. Tonight on Vital Signs on the Front Lines, we confront the uncomfortable questions. Is Nigeria any closer to ending catastrophic healthcare spending? Is the Vulnerable Group Fund reaching those it was created to protect? As President Bola Tinubu's administration pursues an ambitious health sector reform agenda, can the NHIA become the institution that finally delivers affordable health care to every Nigerian? Or will universal health coverage remain another promise that exists only on paper? Dr. Kelechi Ohiri, thank you so much for speaking with us on Vital Signs.
Thank you for having me on Vital Signs.
So let's talk about the NHIA.
Okay.
What's the mandate given to the NHIA by the Tinubu administration?
So the NHIA, in discussing its mandate, I think it's important to start with the origins, right? I think if one was to simplify it, it's really just to provide financial access to good quality healthcare. But that's, as simple as it sounds, it's quite loaded. It means, one, it's financial access, because we know there are many barriers to care. One of the major ones is financial. Second is that it's financial access for whom? It means that it's for all Nigerians and all Nigerian residents, but the Tinubu administration has prioritized the poor, so there's an equity mandate. And the third part of that comment is good quality healthcare, which means NHIA also has a mandate as a purchaser to make sure that what it is buying is of good quality. So our mandate, therefore, is to provide financing that enables people access healthcare, but healthcare that is of good quality. And the Tinubu administration has made achievement of universal health coverage a key part of the health sector reform. And NHIA's role is on the demand side to ensure that people are protected from the catastrophic costs of healthcare. And that's why when we started as part of the Health Sector Renewal Investment Initiative, the role of NHIA was enshrined in the second pillar about access to care. And that's what we view our mandate as. And this was further elaborated in the 2022 NHIA Act that specified and clarified NHIA's functions, which are both to provide insurance, largely for public sector workers and others, but also to promote, regulate, and integrate health insurance. But we can go into that in a lot more detail later.
How long have you been Director General here?
About 2.5 years.
So what did you meet on ground? And, just so Nigerians can understand, we've not really heard much about the NHIA in the past. But you're here, and I'm seeing there's some great news that there's an increase in people who are partaking of the NHIA. But just so you can give us an idea of what you found when you came here, and what are some of the challenges that you had to face initially?
So I think first, the journey on health insurance and UHC is not an easy one, and I think one has to be charitable to predecessors because it's quite a heavy lift trying to get people covered. So I believe all those who ran what it used to be called NHIS did their best and kept on moving forward. So we build on where they, on the foundations and the pillars that they laid down. However, when I was appointed to the role, even before I resumed, I don't know, maybe it's Murphy's Law. You start hearing more about health insurance, right? And it became increasingly scary because we had an industry that was, to put it mildly, it was in disarray and chaos, right? There were lots of complaints. The providers were threatening to pull out of health insurance. And then the private health insurers complained a lot as well. So I read all these things. And then when I came in, I tried to first listen, understand, and generally appraise what was on ground. So what was on ground was that historically, we hadn't made much progress, partly because we didn't have the enabling laws, but also there are other factors that may have led to that. And it was important to first establish a baseline of where things were. So what we found was that there were roughly about 16 million Nigerians covered, which was not bad. We had a target to increase by 20% those covered by within 4 years. I think we've exceeded that target already as of now.
President Bola Ahmed Tinubu's policy interventions to the NHIA have accelerated implementation of the NHIA Act inherited by his administration, shifted focus from voluntary enrollment to universal health coverage. Insisting that health insurance is mandatory, the Tinubu administration has continued enforcement of provisions making health insurance mandatory for all Nigerians, encouraged states to domesticate the NHIA Act, and establish state health insurance agencies. The policies have also resulted in the expansion of the Vulnerable Group Fund, prioritizing the enrollment of poor and vulnerable Nigerians, and expanding coverage to pregnant women, children under 5, elderly persons, persons with disabilities, and indigent households. On the 1-hour emergency treatment policy, the Tinubu administration has directed NHIA accredited hospitals to immediately stabilize insured patients within 1 hour before administrative processes and introduced sanctions against hospitals refusing emergency treatments. Under the provider payment reforms, the administration of President Bola Ahmed Tinubu has approved an upward review of capitation payments, free-for-service tariffs, and is intending to improve quality of healthcare and retain providers within the NHIA system. With the Enrollee Protection Framework, the Tinubu administration has strengthened enforcement against hospitals, charging illegal fees, denying covered services, and rejecting NHIA patients, and has gone even further to introduce quicker complaint resolution mechanisms. With the expansion of benefit packages, access has been increased to maternal health care, chronic disease management, emergency services, dialysis support, and cancer-related interventions in collaboration with other government programs. Under digital health insurance reforms, the NHIA has begun digitizing claims processing, enrollee verification, complaint management, and provider monitoring. At the subnational levels, health insurance expansion has supported states to establish and strengthen state health insurance agencies, improved integration between federal and state insurance programs. Under formal and informal sector expansion, the Tinubu administration introduced more flexible health insurance products targeting artisans, traders, farmers, and self-employed Nigerians.
We also found that the tariffs that were being used to reimburse for healthcare had not been reviewed in a while because actuarial studies that typically underpin such tariffs had not been done. And that was probably the root cause of a lot of the angst from healthcare providers, hospitals, doctors, etc. So one of the first things I did was to initiate actuarial reviews of the existing plan that it was offered. So that means looking at the costs, looking at the reality of market prices for providing healthcare, and then having an extensive stakeholder engagement. And when that was concluded, we increased the tariffs. So we pay things called capitation. That basically means for all your primary care, if this is the hospital that you pick, the hospital gets a certain amount to take care of your primary healthcare needs. Because every health system should focus on prevention and primary care. That's the bedrock of a health system. And then the second payment is fee for service, so that when you need to be referred for additional care, then the hospital that provides that care is reimbursed based on certain tariffs. Now that means that the reimbursements that are given to the hospitals and the HMOs that hadn't been reviewed were not keeping pace with medical inflation and the price of medicines. So what we did was review that in line with the actuarial work that was done. So it led to about almost a doubling of capitation and an increase in fee for service by about 370%. So that's steadied and calmed the industry because now we're paying realistic tariffs and reimbursing more realistically, because you can't say you want to provide quality care if you're not ready to pay for it. Because what happens is that ultimately the person suffers. So this was our mandate first, to protect the person who is the enrollee by ensuring that when you pay for care, that what they are accessing is of good quality. And they say you should come to equity with clean hands. So we had to first do our own part, which is ensure that what we're reimbursing was fair. And then layered on that are now additional activities we have undertaken to enforce these things and make sure that years of neglect of those who are insured, we have to undo that and make sure people realize that the Nigerian enrollee or patients should be at the center of the system. And everything that we do has to center around making sure that they have access to care. So any excuse for denying or delaying care had to be taken out. But it was important we started with, is what we're paying fair? If it's fair, then do your own part. So that's what we started with. So that was one of the first things that we met, and that was how we started tackling some of the challenges in the sector. But there are other things I'm sure that will come up in the course of the conversation.
Yes, they will. Just in practical terms, you stated earlier that the Tinubu administration, they're moving, they're trying to do equity care, isn't it? They're trying to get everyone on board.
Yes.
So they're looking at the poor. So in simple terms, how does the NHA and the NHIA help the poorest in our communities to access healthcare? How does it work?
Okay, excellent. So one of the things, of course, after listening, we have like 4 main pillars. One was to expand coverage for all Nigerians. But the second pillar is a very important one to address this, and that's the equity pillar. Because the way we want to go, I mean, you can decide you want to expand coverage by waiting for it to trickle down from the rich to the middle class before it gets to the poor. But what this administration is doing is being very intentional about targeting the poor. So I'll just speak to like three programs or three approaches that's we're undertaking to make that happen. So the first is what is called the Basic Healthcare Provision Fund. We know that 1% of consolidated revenue goes to primary care. Roughly half of that is through NHIA's pathway. So for that, we work with the state health insurance schemes and we target the poor. We have a vulnerability tool. So across all the states in the country, the poor are targeted and enrolled. They don't have to pay any premium. That covers their premium.
A vulnerability tool?
Yes.
Is it like an app?
It's
or you
not
register at hospitals? What is it?
So so typically they go to communities, right? So there's community, targeting where in certain communities, you speak to the stakeholders, you know who the poorest households are, and with that you enroll. There's also a national social register that could start, you could use as a reference point, but you still have to verify and validate that these are really the poorest people in the communities that you bring on board. And vulnerability manifests in many ways. One is poverty, right, which you can see. But there are also other forms of vulnerability that people may have as a result of either the type of diseases that they suffer from, or gender or other things, displaced persons, etc. So the tool is just to make sure that we're not leaving anybody out in our notion of defining who the poor and vulnerable are.
Under the Tinubu administration, more than 22 million Nigerians enrolled in health insurance, the highest enrollment recorded by the NHIA to date. Approximately 35% growth in enrollment within a year under Dr. Ohiri's leadership. Increased reimbursement rates for healthcare providers. Expansion of coverage for vulnerable populations through the Vulnerable Group Fund. Enforcement actions against healthcare facilities that illegally charged or denied services to NHIA enrollees. Wider state participation in state insurance schemes supporting progress towards universal health coverage. These interventions collectively reflect the administration's strategy of combining policy reform, increased domestic financing, provider payment reforms, digital modernization, and stronger regulatory enforcement to expand health insurance coverage and reduce the financial burden of healthcare on Nigerians.
So roughly about 2.5 million people are currently covered and paid for by the Basic Healthcare Provision Fund. And their premiums are covered, and if they are ill, they'll go to the primary healthcare center that they registered in. We send money to those primary healthcare centers as a capitation, and then when they are referred, fee-for-service covers for them. So that's one. And of course, increasingly, those numbers, we hope that by a year from now should get to about 4 or 5 million. And then if the bill that has recently passed goes through and gets assented to, we hope that number will also get to double that amount. But we didn't stop at that. What this administration has also done is identify that one of the major challenges we face in Nigeria is maternal mortality, and people are very aware of that. And our way of contributing to that is to make sure that when a woman comes with an emergency, that again, financial access is not the barrier. You know how in a lot of hospitals, if you don't have money to pay, they send you away. And so what we did was first identify, hospitals that we've accredited, starting with a full list of hospitals in Nigeria, secondary and tertiary, because we're focusing on the comprehensive emergency obstetric care, things that require higher level care. So this is not primary care now. This is an emergency is happening. The woman needs blood. She needs a CS, and what do you do to intervene? And so we looked at the hospitals that had the highest mortalities and the highest numbers of people, of births, and we prioritized as such. So right now we have about 200, almost 300 facilities across the country that we have empaneled to do this program. So any woman that can't afford care shows up at a hospital, with a maternal emergency is treated, and then the facility is reimbursed. And then after that person is now well, then you insure them so that subsequent issues they face are not. It's already covered, so they don't have to be out of pocket. And we're doing it this way as an innovation because if we are waiting until everybody's covered with insurance, we'll still keep losing people. So how do we attack this issue of maternal death, at least from a financial access perspective, while still meeting objectives of getting more people enrolled? Because in medicine, typically, there are 3 delays that are dangerous. So there's a first delay, which is the delay from deciding to seek care. And many reasons could account for this, including, if I don't have money, why am I bothering? So we aim to provide that assurance so people can go. So there's a second delay, which is, from when you've decided, how do you get to the hospital? And so a lot of other interventions with emergency services takes care of that. But there's the third one, which is when you get there, do they turn you away? Do they attend to you immediately? So that delay from when you get there to when they actually start treating you definitively. Most times that delay is because of money. And what we're saying is delays can be fatal. So don't drag or say, go and pay here and come back there. Just treat. And we are going to provide that guarantee that that woman her care will be paid for and reimbursed by us. Roughly almost 50,000 people so far benefited from that since the program came up about 1.5 years ago. And this is across the country. The third program is, this also extends to women who are not at risk of dying. But we have a problem of obstetric fistula in Nigeria where due to prolonged labor, a lot of women develop it. They tend to be ostracized, stigmatized for something that is curable and treatable. So it's not just the maternal mortality we're preventing, we're also mitigating the maternal morbidity. And roughly 4,800 women with fistula in Nigeria have had their fistula surgeries repaired. We pay for whether it's conservative treatment or surgical treatment that they require.
Does this apply to both private and public hospitals?
Yes. In the NHIA, we understand that Nigeria has a mixed healthcare system. Mm-hmm. And so we are agnostic as to whether it's public or private, as long as there's good quality care and access, and then our tariffs apply across board. And so we have seen private providers who are also part of this, including faith-based organizations as well. Now, for fistula, it requires a higher level of expertise. So there are roughly 18 hospitals nationwide, including 4 national obstetric fistula centers that are only dedicated to that are involved in treating that. Of course, there are other partners involved in helping to upskill some of the hospitals. So the more people or the more hospitals that can do it, the more we'll onboard them and then we'll keep going. But so far, we're quite encouraged by the fact that some people have gotten their lives back as a result of this.
Our health fellow this week is Ote Anastasia Oklika from Okpoku local government area of Benue State. As part of a capstone project, she's leading a menstrual hygiene and general health sensitization initiative aimed at raising awareness on menstrual hygiene management, promoting healthy practices, and educating members of her community on general health and well-being. Through this project, she seeks to improve health literacy, reduce stigma surrounding menstruation, and encourage better hygiene practices, particularly among girls and women.
My name is Ote Anastasia Oklika, National Health Fellow representing Okpoku local government area of Benue State. Part of my assignment as a National Health Fellow, I visited facilities and I supervised the measles and rubella campaign I realized at the process of the campaign that the major problem with the campaign was misinformation with the community. I spent time in town halls, moving from doorsteps to doorsteps, visiting parents, caregivers, community leaders, and enlightening them about the campaign, because some of these parents refused to bring their children for vaccination because of the misconceptions they had about the vaccine. So I spent some time with my team, moving with the vaccination team from halls to halls, from places to places, from communities to community, making sure that every eligible child was vaccinated and counted and recorded appropriately. And then moving on with my assignments in the community, I discovered that another problem was some girls leaving schools because of their messes, the menstrual cramp, they have stained in school. And then because of that, some of their students make jest of them. And then because of the stigma and the silence around the situation, they will be absent from school. And so I took upon myself to train 25 peer educators to continue the knowledge and the lesson after me. I went to 4 schools, Ebute Memorial, Lion Science, and other schools. I distributed over 700 pads and hygiene kits, giving them lectures in the hall. I involved their parents and the community leaders because the knowledge, the girls need to be enlightened even from the home. Their parents need to be aware. I gave lectures and I made sure that these 25 peer educators went to other communities and educated their peers on the safe process of menstruation, hygiene, and the physical well-being. So giving to my community, it's a plus for me and to my community. This program has really helped me. It has changed my knowledge about leadership. Giving to my community was a thing of pride to me. To the Minister of Health and Social Welfare, Professor Mohammed, sir, I would like to say a very big thank you for giving I and other fellows this opportunity to give our communities, and then for investing this heavy on us. Sir, we are proud and saying thank you from Opoku local government, and then to the President of the Federal Republic of Nigeria for accepting this initiative. Thank you very much, sir, for this opportunity.
As Nigeria pursues the ambitious goal of universal health coverage, the responsibility doesn't rest on one institution alone. It requires bold leadership, sustained political will, and effective implementation. From President Bola Ahmed Tinubu's commitment to strengthening the nation's health sector, to the reforms being driven by the Coordinating Minister of Health and Social Welfare, Professor Mohammed Ali Pate, and the National Health Insurance Authority, under the leadership of Dr. Kelechi Ohiri, the foundation is being laid for a healthcare system that is more inclusive, more affordable, and more accessible. The true measure of success, however, will not be the policies announced, but the lives transformed, and that will be our focus next week on Vital Signs on the Front Lines. Until then, I'm Kayla Megwa, reminding you that health is your true wealth.